Good afternoon, students. Today we're talking about diabetes mellitus type 2 and outpatient settings and their complications. Diabetes mellitus is a heterogeneous group of metabolic disease caused by chronic hyperglycemia, which is a result of impaired insulin production, secretion, insulin action, or both. Type 2 diabetes is a disease caused by hyperglycemia caused by isolated destruction of pancreas beta cells, usually leading to absolute insulin deficiency. Type 2 diabetes is a disease caused by hyperglycemia caused primarily by insulin resistance and relative insulin deficiency. Gestational diabetes is diabetes caused by hyperglycemia first detected during pregnancy but not meeting the criteria for manifest of pre-gestational diabetes. Prevalence of the diabetes in age, just prevalence of type 2 diabetes in adults is about 15% in the United States and about 10% globally. The age-adjusted incidence of type 2 diabetes in United adults is about 6 per 1,000 persons, however. An estimated 23% of United States adults with type 2 diabetes are undiagnosed. Type 2 diabetes disproportionately affects adults with obesity and racial and ethnic minorities. For example, age-adjusted prevalence of type 2 diabetes in high and black 90% and Hispanic 21% adults than in white adults, about 12%. Risk factors for prediabetes and type 2 diabetes. Its criteria for testing for diabetes mellitus in asymptomatic adults. And these risk factors are age, equal or more certified without other risk factors, first degree relative with diabetes, history of cardiovascular disease, overweight or obesity, sedentary lifestyle, a member of age at risk racial or ethnic group, Asian, African American, Hispanic, Native Americans, or Pacific Islander. Higher density, low cholesterol or triglyceride level, more than in norm, impaired glucose tolerance and impaired fasting glucose or an metabolic syndrome. Polycystic ovary syndrome, acanthosis nigricans, non-alcoholic fatty liver disease, hypertension with BP more than 140/90, or therapy for hypertension, history of gestational diabetes mellitus, or delivery of baby weighing more than 4 kilos. Anti-epileptic therapy for schizophrenia or severe bipolar disease. Sleep disorder, including obstructive sleep apnea, chronic sleep deprivation, and night shift occupation. Diagnosis of diabetes mellitus. It is carried out on the basis of risk factors, clinical symptoms, and laboratory determination of the concentration of glucose in the blood or up the stomach 2 hours after a load of 25 grams of glucose randomly at night of the day regarding of the time of meal. Glycated hemoglobin, glycated hemoglobin. The diagnosis of diabetes mellitus requires two different fasting glucose and glycated hemoglobin. Abnormal test results, there is from the same sample or two abnormal results of samples drawn on different days. This is the glucose testing and glycated hemoglobin interpretation. So it's normal, prediabetes, and diabetes. This norm is for United States, not for other country. So I give it to you in these units. So you can see that fasting plasma glucose in norm should be less than 100. Fasting plasma glucose, if it's more than 26, this is a diabetes. And if it's middle from 100 to 125, this is pre-diabetes. In pain fasting glucose in pre-diabetes, it's you see the numbers according to this table. How can you say that it's a norm, pre-diabetes or diabetes? And here you can see how to check glucose criteria and use 75-gram oral glucose test. Clinical criteria: polydipsia, polyuria, weakness, fatigue, recurrent skin infections, candidiasis, vulvitis, Bonitis, symptoms of dehydration and catabolism, progressive weight loss, dry skin and mucous membranes, decreased skin turgor, sunken eyes, vomiting, smell breath, and smell of acetone in the inhaled air. The presence and severity of clinical manifestation is determined by the degree decompensation of carbohydrate metabolism. Clinical classification of complications can be acute or chronic. Acute, ketoacidotic coma or diabetic ketoacidosis, hyperosmolar coma or hyperosmolar hyperglycemic state, lactate acidosis, and hypoglycemic coma or hypoglycemia. In this lecture, we're talking about acute conditions only according to chronic, because acute conditions you will discuss in another cycle. Chronic conditions: diabetic retinopathy, diabetic nephropathy, diabetic neuropathy, and diabetic foot syndrome, osteoarthropathy. Diabetic nephropathy. It's a specific kidney damage in diabetes accompanied by the development nodular or diffuse glomerulosclerosis in leading to development or terminal stage of chronic kidney disease. Required renal replacement surgery. And you should know from the previous lecture that the 5 stages of chronic kidney disease. Last stage, this is the 5th stage, with GFR less than 50. Chronic kidney disease is a concept that slight kidney damage or decrease of GFR less than 60. This chronic kidney disease persistent for at least 3 months, regardless of the primary clinical diagnosis. Diagnosis of diabetic nephropathy is based on the presence of increased urinary protein excretion and or decreased GFR in the absence of symptoms and sign of primary renal pathology. So the first main reason is diabetes. Clinical manifestations are non-specific and do not allow verification of pathology. Diabetic neuropathy. Diabetic peripheral neuropathy is diffuse or focal damage to peripheral nerves caused by diabetes, clinical apparent or subclinical in the absence or another possible etiology. Classification. According to clinical fonts can be sensor, symmetrical, asymmetrical, motor, to symmetrical, asymmetrical, sensor, motor, pain. The presence of symptoms that intensively in the evening, burning, acute pain. It can be pain, absence or impairment of intensivity and decrease of absent reflexes. Paleness of in combination with complete or partial loss of sensitivity. No symptoms or numbness of the feet, decreased pain and temperature sensitivity, decreased or absent reflexes. Uncomplicated and complicated. Complicated by neuropathic foot deformation, diabetic foot syndrome, and no traumatic amputations. Clinical criteria for diabetic autonomic cardiovascular neuropathy: rest in tachycardia, decreased exercise tolerance, inoperative cardiovascular instability or orthostatic hypotension, syndromes of orthostatic tachycardia and bradycardia, silent myocardial ischemia, innervation heart syndrome, vascular hypersensitivity to catecholamines, ECG changes such as ST interval depression, QT interval prolongation, positive T-wave inversion. It can be prosecutionary, ST segment elevation, edema syndrome, arrhythmias, hypertension, cardiorespiratory arrest, systole and distal function of the left ventricle, or sudden deaths. Charcot-diabetic osteoarthropathy. This aseptic, progressive, destructive unilateral or bilateral damage to the bones and joints of the foot associated with diabetic neuropathy and leading to limb deformation and loss of support function. Clinical criteria depending on the state of the disease. In acute, is active form swelling, hyperemia, hyperemia of the affected limb in absence of infection. Or chronic inactive, typical deformation of the foot or the ankle joint. Diabetic foot syndrome, a condition in which a patient with diabetes on the feet there is a focus of infection. All arts are on the destruction of the deep tissue of the foot, including the osteoarticular braids of the foot associated with neurological disorders or a decrease in the main blood flow in the arteries of the lower extremities of various degree of severity. It's 5 degrees. 0 degrees, no open skin lesions. It should be taken into account that counted the expressed hyperkeratosis can mask autolysis of soft tissue. First degree, superficial ulcer involving the epidermis and dermis. Degree, ulcer necrotic defect involving subcutaneous fat fiber, ligaments, tendons, and muscle without bone damage. Grade 3, deep tissue damage with bone, environmental and development, osteomyelitis process, purulent arthritis, can be phlegmous abscesses. Fourth grade, this is a gangrene of the finger part of the foot. And the last, it's extensive gangrene volume 2 or all 3 parts of the foot. Diabetic retinopathy is a microvascular complication of diabetes characterized by retinal damage as a result of ischemia, increased permeability of the vascular endothelial dysfunction, leading to a significant decrease in vision up to its complete loss. Classification by stages according to change in retinal vessels can be non-proliferative, perproliferative, and proliferative. Non-proliferative exists microaneurysm, small retinal hemorrhage, retinal edema, hard and soft external lesions. Preproliferative. Addition of venous abnormalities, many soft and hard exudates, intraretinal microvascular abnormalities, larger retinal hemorrhages. Proliferative, neovascularization, retinal, preretinal, intraretinal hemorrhages, epiretinal and vitreoretinal fibrosis, traction, retinal detachment. Treatment of type diabetes 2. Major treatment goals for patients with type 2 diabetes include great glycemic control and primary and secondary prevention of atherosclerotic cardiovascular and kidney disease, which occurs for nearly half of the deaths among adults with type 2 diabetes. Despite multiple treatment options, 16% of adults with type 2 diabetes had inadequate glycemic control with gated hemoglobin levels of 9% or higher. Inadequate glycemic control is more prevalent among Black and Hispanic adults and among white adults, 9% with type 2 diabetes. Excess weight results in insulin resistance and increases the risk for prediabetes and diabetes type 2, but also leads to multiple complications beyond dysglycemia that comprise A, B, C, D and lead to excess morbidity and mortality. Lifestyle intervention to achieve weight loss is a key pillar of the comprehensive treatment of a person with prediabetes to decrease progression to diabetes 2. Weight loss also improves many of the cardiometabolic and biochemical components of ABCD, including increasing glycemia, dyslipidemia, elevated BP, cardiovascular diseases, non-alcoholic fatty liver disease, sleep apnea, and osteoarthritis. albeit with various should be rated from 5% to 15% of body weight. And we're talking about pharmacological treatment. They include taken orally anti-glycemic drugs. And this eight group of the drugs, first this big one night, this metformin diet release. Sulfonylurea drugs such as glibenclamide, glycolazide, glucoidone, atazolindiones, pioglitazone, DPP4 inhibitors, this dipeptidase 4 inhibitors, sitagliptin, vildagliptin, glucose sodium contributor type inhibitors, SGLT, and empagliflozin. It can be taken injectable anti-hypertensive drugs injected subcutaneously. Glucagon like 1 receptor agonist, GLP-1, liraglutide, or the last group is insulin. Treatment of patients pharmacological treatment includes this same group, but what now? GLP-1 agonist and glucose-dependent insulinotropic polypeptide agonist, sodium glucose contraceptor type inhibitors, dipeptidase 4 inhibitors, and long-action insulin. This main neuropharmacological treatment. Step-by-step algorithm for individual selection glucose lowering therapy. Depending on glycated hemoglobin level at the time of diagnosis, if the initial glycated hemoglobin from 6.5 to 7.5, it can be monotherapy, most often this with metformin. If its initial glycated hemoglobin more than 7.5, it's 7.6 to 10, and combination of 2 or 3 drugs with different mechanism actions. If its glycated hemoglobin more than 10, its combination of injectable is with insulin or oral glucose-lowering drugs on a basal bolus insulin regime. Metformin is recommended as a first-line drug for glucose-lowering therapy for everyone patient with good tolerance and no medical contraindications. Combined glucose-lowering therapy is prescribed if against the background of monotherapy with individual target indications for compensation of carbohydrate metabolism. This is a complication certain model for the care of person with overweight and obesity. Such that a lot of patient has overweight or obesity. This stages treatment according to BMI. If it's a for norm, BMI less than 25, and that's or more than 25, but and patient with obesity too. So all according to these stages. So we see that first this stage 1, now ABC complications, and there you can see what the ABC complications and include prediabetes, dyslipidemia, hypertension, good fatty liver disease, cardiovascular disease, chronic kidney disease, osteoarthritis, asthma, or GERD, urinary problem. You can see this and you should improve the nutrition, then physical activity, sleep, counseling, medications, and intervention. So all according to the weight. More weight, more bone mass, more and even surgical treatment, bariatric surgical options. Then this complication central algorithm for glycemic control, such that a lot of patients have a lot of another diseases such as cardiovascular disease, heart failure, stroke, chronic kidney disease. It should be treatment according to these diseases. This is a cardiovascular disease or risk of cardiovascular disease. The first choice, this is GLP uh, receptor antagonist or CGLT drugs. If it's a heart failure, CGLT drugs is the stroke GLP receptor antagonist or pioglitazone. If it's a chronic kidney disease, CGLT or GLP receptor antagonist. If it's a known order of medication, suggest for selection. And then you can see that you can continue or start metformin and add all the drug is not glycemic tablet at less than 3 months. Titrate to maximum tolerance dose or add agent not is used. And so you can see what you can add. ABCVD risk reduction organism with hypertension. The goal for patients with hypertension and diabetes is systolic less than 130, diastolic less than 80. It's for common patient, for a lot of patients, but patients with considered with microalbuminuria, the guidelines said that it should be less than systolic 120, diastolic less than 70. Of course, lifestyle intervention, decrease sodium intake, diet, like for all patients with arterial hypertension, physical activity, achieve optimal weight. Then you can prescribe for patients. You should prescribe RBC or AC inhibitors. ACE inhibitors. Then to treat medication dose or add therapy every 2-3 months to reach goal. Then add thiazides or calcium channel blockers, then combined with beta blockers, selective beta blockers, and mineral corticosteroids. And additional adversive drugs, central beta 2 agonist, peripheral alpha blockers, petrolazine, if it's you can control your BP with another drugs. Recommendation 1. According to the American College of Physicians, recommends adding a sodium glucose contraceptive 2 inhibitor or GLP-1 agonist to metformin and lifestyle modification does with type 2 diabetes and inadequate glycemic control. Use an SGLT2 inhibitor to reduce the risk for all-cause mortality, major cardiovascular events, progression of chronic kidney disease, and hospitalization due to congestive heart failure. Use a GLP-1 agonist to reduce the risk for all-cause mortality, major cardiovascular events, and stroke. Recommendation 2. Recommendations against adding a DPP-4 inhibitors to metformin and lifestyle modification and thus with type 2 diabetes, inadequate glycemic control to reduce mortality and all-cause mortality. Glycated hemoglobin, glucose management indicator, is a convinced measure in the clinical setting that is widely used to assess glycemic control. It should be measured every 3 months when not a goal and minimum of twice per year in a person at goal. For most patients, glycated hemoglobin should be targeted less than 6.5%. Glycated hemoglobin also has limitations and can be increased in some population, including people with treated red blood cells, lifespan hemoglobinopathies, chronic kidney disease, and some racial backgrounds. You should avoid hypoglycemia for your patient. Hypoglycemia, defined as blood glucose less than 70 mg per deciliter, is associated with an increased risk for adverse outcomes, including mortality. Agents such as DPP-4, GLP-1 receptor antagonists, and SGLT2 inhibitors have a lower risk of hypoglycemia compared with that of insulin and are preferred to achieve optimal glycemic goals. Treatment of glycemia is an essential component of diabetes and prediabetic damage. These are our goals all according to risk. risk, cardiovascular risk. High risk is the risk 10-year risk less than 10. Diabetes rate less than 10 years and less than 2 additional traditional A, B, C with risk factors. And the target goal for low density cholesterol less than 100. It's a very high risk. It's a 10-year risk from 10 to 20. This means the diabetes duration more than 10 years with 2 or equal to traditional risk factors and no target damage organs. The goal of low density cholesterol less than 70. Extreme risk. It's a 10-year risk more than 20. It's long duration of diabetes for diabetes. It's a present target damage organ, left ventricular systolic or diastolic dysfunction, glomerular filtration rate less than 45. This is the goal of low density cholesterol level less than 55. Initiate a statin as first-line therapy. A statin should be used as the first-line therapy for dyslipidemia in persons with diabetes type 2. High-risk patients should be started on moderate insulin statin therapy, which results in a low density cholesterol reduced in the range of from 30 to 40. For persons at every high risk and extreme risk, high intensity statin therapy, which lowers low density cholesterol by 50 to 60, should be started regardless of baseline low density cholesterol level. Newly diagnosed type 2 diabetes with glycated hemoglobin more than 10. This is the initial indication for initial insulin therapy. And now talking about initial indicated for initial insulin therapy. Very high, more than 10 glycated hemoglobin, and the presence of clinical symptoms of decompensation. This is the first and the main indication for insulin therapy. Second, failure to achieve individual glycemic control goals, again, the background lifestyle modification, therapeutic dosage of antihypertensive drugs or their combination for 3 months. Third, the presence of medical contraindications of the prescription or intolerance to other anti-hyperglycemic drugs. Fourth, ketoacidosis. Fifth, the need to emerge surgical interventions, acute illnesses, or exacerbations of chronic disease. It's, for example, if a patient has COVID-19 pneumonia, it's acute illnesses, and patient need to use insulin. Accompanied by signs of decompensation of diabetes. Insulin therapy may be temporary in these cases. Basal insulin is prescribed as the initial dose of 10 units a day, subcutaneously with further titration of the dose according to the glycemic level. Thank you for your attention. See you in our classes.